You know, when you look at a patch of weeds in a garden, it's incredibly tempting to just yank out the ones you can see.
Right, the obvious ones.
Yeah, exactly. You pull a dandelion, you wipe your hands off, and you think, well, the job is done. But anyone who has actually tried to maintain a garden knows that the real story, the true ecosystem, is entirely underground.
Oh, absolutely. It's all beneath the surface.
Right. There is this vast, invisible subterranean root system. Those roots are interconnected. They're, sharing nutrients, and they are spreading silently in the dark.
Mm-hmm.
If you only chop off the visible weeds above ground, that subterranean system doesn't just survive, it actually thrives. It expands.
I mean, that is just a phenomenal way to visualize the landscape of sexually transmitted infections.
It really fits, doesn't it?
It does, because what we see on the surface, the symptomatic patients arriving at a clinic seeking treatment, the people who actually know they are sick, those are just the visible weeds.
Just the tip of the iceberg, really.
Exactly. The subterranean root system represents literally everything else. It's the asymptomatic transmission, the really complex hidden sexual networks, and the deeply entrenched social determinants of health that keep the whole ecosystem fed.
Yeah.
Public health, in this context, isn't just about pulling weeds. It's the science of mapping and neutralizing that entire underground network.
And that is exactly our mission for you today. Welcome to the Deep Dive. We are jumping into the hidden world of sexually transmitted infections, and we're going to look at a mountain of epidemiological data from the Oxford textbook of global public health that completely flips how we think about fighting them.
We really need to build a rigorous framework today.
Yes, from the ground up. This isn't just about memorizing pathogens. We want to understand the actual mechanisms of transmission, differentiate between core concepts like incidence versus prevalence, and really get to the bottom of why public health decisions are made in the face of such immense biological and social complexity.
Right. We have to follow the thread from the initial biological exposure, trace it to the individual outcome, and ultimately map out the system's level impact on global populations.
So to anchor us, before we get into the heavy biology, let me just share a staggering data point.
Go for it.
When we look at global estimates, specifically the comprehensive models from the World Health Organization, every single year, there are nearly 500 million new cases of curable sexually transmitted infections globally.
It's hard to even picture that number.
Let that sink in for a second. 500 million.
Right.
And that doesn't even touch the billions of lifelong viral infections.
Yeah, the scale is, it's almost difficult to comprehend. In terms of the sheer global burden of disease, curable STIs are exceeded only by a handful of things.
Like what? Malaria?
Yeah, malaria, diarrheal diseases, and lower respiratory infections. That's about it. But to understand how to fight this subterranean network, we first have to categorize the threats, right? We have to look at their biological life cycles and how they actually interact with human populations.
Okay, let's draw that biological divide. Because if you look at the landscape of pathogens, there are, over 30 different bugs that can be transmitted sexually?
Roughly, yeah.
But we can synthesize them into a very clean framework, broadly dividing them into two camps, the curable and the viral.
And that biological distinction between those two camps, it basically dictates our entire public health strategy.
How so?
Well, on one side, we have what we might call the curable four. These are 3 bacterial infections, chlamydia, gonorrhea, and syphilis, along with 1 parasitic infection, trichomoniasis.
Right.
Because they are bacteria and parasites, they have cellular structures that we can physically target. We can cure them with readily available antibiotics.
But the catch is, curing a bacterial infection doesn't give you a magical shield afterward.
Oh, definitely not.
Like if I get strep throat, take penicillin, and get cured, I can still get strep throat again next year. The same applies here, right?
Exactly the same. You can be cured of chlamydia on a Tuesday and be reinfected by Thursday if you're exposed again.
Wow.
The lack of lasting immunity is a massive, massive driver of the epidemic. Now, on the other side of the divide, we have the lifelong viral infections.
Right, the viruses.
Yeah, this group includes human papillomavirus, or HPV, herpes simplex virus type 2, or HSV2, the hepatitis viruses B and C, and of course, HIV.
And viruses play by entirely different rules, don't they? They aren't just, swimming around in the bloodstream.
No, they actually invade our cells. They hijack our own biological machinery to replicate.
Which is why they are not cured with standard antimicrobial agents.
Right. We can sometimes ameliorate the symptoms or suppress the viral replication with antivirals, but they tend to cause lifelong persistent infections. They integrate into the host.
Okay, let's unpack this for you listening, because we need to get our terminology straight if we're going to talk about 500 million infections.
Terminology is everything in epidemiology.
When we talk about these two different groups, epidemiologists use two very specific terms, incidence and prevalence. I want to make sure I have this right.
Go ahead.
Incidence is the rate of new cases occurring within a specific time period, like a year. So when we talk about the rapid acute spread of the curable 4, we are talking about incidence.
That is the perfect application of the term. That 499 million figure you mentioned earlier, that's incidence.
Just the new ones.
Yeah, it measures the velocity of the spread. Specifically, if we look at the breakdown of those WHO numbers, we see roughly 106 million new cases of chlamydia, 106 million of gonorrhea, 11 million of syphilis, and 276 million of trichomoniasis.
And that's occurring in a single year.
Just 1 year.
So incidence is basically like a speedometer. It tells us how fast the bucket is filling up with water.
I like that analogy.
And prevalence, on the other hand, is measuring the total number of existing cases in a population at a given point in time. It is how full the bucket already is.
Exactly.
And I imagine prevalence is the crucial metric for viral STIs because they accumulate. They don't just happen and go away. They stay in the population.
The bucket analogy is spot on here. With viral STIs, because there is no drain at the bottom of the bucket, no cure, the water level just keeps rising.
So the numbers just get bigger and bigger.
They become staggering in a completely different way. We aren't just looking at new infections per year. We are looking at the total global burden.
What kind of numbers are we talking about for the viruses?
Well, estimates show that roughly 290 million women globally carry HPV. For HSV2, we are looking at 536 million people globally living with the virus.
Over 500 million people living with HSV2. That's intense. And here is the truly terrifying part about that subterranean root system we talked about. The data explicitly shows that the vast majority of these STIs are completely asymptomatic.
Yes, that is the core issue.
You can have a bucket overflowing with 500 million new bacterial infections, and the vast majority of those people feel absolutely nothing. No pain, no fever, no visible signs.
What's fascinating here is how that biological reality completely upends traditional medical models.
How so?
Well, think about it. The entire architecture of modern medicine is based on a really simple premise. You feel sick, you go to a doctor, you get diagnosed, you get treated, and you get tallied in the local health department's statistics.
Right. It relies on the patient making the first move.
Exactly. But if the pathogen has evolved to remain silent in the host, the patient never seeks care. The traditional medical model basically goes blind.
So if the clinics are blind, how can epidemiologists possibly measure a disease burden? If no one knows they are sick, how do we arrive at a number like 499 million?
It requires a massive shift from passive observation, just waiting for sick people to show up, to active surveillance and modeled estimates.
What does active surveillance look like in practice?
Epidemiologists have to conduct discrete representative population-based studies. They literally go out into communities, test a randomized sample of healthy-feeling people, and find out what percentage are silently carrying an infection.
Okay, so they test a small group and then scale it up.
Right. They mathematically extrapolate that across the broader population, adjusting for underreporting and demographic factors.
But that active surveillance has to be incredibly expensive and logistically difficult.
It is incredibly difficult, which brings up a pretty troubling trend in global health monitoring.
What's the trend?
The authors of those major WHO estimates noted that the number of reliable, rigorous studies meeting their entry criteria actually dropped dramatically between 2005 and 2008.
Oh, wow.
Yeah, the data flow is constantly threatened by a lack of funding and infrastructure. We're losing our visibility.
Which brings us to a massive paradox that I've been trying to wrap my head around in this chapter.
The rising incidence.
Yes. Wait, we have a cure for syphilis. We had a cure for chlamydia. We have had antibiotics like penicillin for almost a century. We know exactly what causes these diseases, and we know exactly how to kill the bacteria.
It's true.
So why are the incidence numbers actually going up? When you look at the historical data, incidence rates rose in most regions, almost doubling in the Americas. How are we losing ground to a curable disease?
It's one of the most profound paradoxes in public health today. It comes down to a perfect storm of biological and behavioral factors.
Okay, break that down for us.
First, as we established, there is no lasting immunity. Second, human behavioral factors and sexual networks are constantly evolving, often much faster than public health messaging can keep up with.
Right.
But third, And perhaps most importantly is the limitation of our screening practices.
Because the infections are asymptomatic, so they just continue to spread undetected.
Yeah.
We are only treating the visible weeds.
Exactly. We are waiting for the weeds to sprout flowers before we pull them. Meanwhile, the roots are spreading everywhere.
So because the numbers are rising despite available cures, we need to look beyond the immediate infection.
We do.
Hmm.
We need to understand the long-term systemic devastation these pathogens cause.
We have to move our framework from just looking at an individual exposure and start looking at generational outcomes. Let's trace the actual biological trajectory of an untreated asymptomatic infection.
Let's do it.
Let's take chlamydia trachomatis or Neisseria gonorrhoeae.
Let's trace that path in a female patient. So she acquires the bacteria. She has no symptoms.
Okay.
If left untreated, over weeks or months, these bacteria can ascend from the cervix, travel up into the uterus, and enter the upper reproductive tract.
And that causes pelvic inflammatory disease, or PID.
Correct.
And we need to be clear for our clinical listeners that PID isn't just a brief, uncomfortable inflammation. This is a severe tissue-altering event.
It really is. The body's immune system attacks the bacteria in the fallopian tubes, causing intense inflammation. And as that inflammation heals, it leaves behind rigid scar tissue.
And that scarring acts like a physical roadblock in the fallopian tubes, right?
Yes, it fundamentally alters the delicate architecture of the reproductive system.
Which leads to what?
It leads directly to tubal factor infertility. This affects up to 25% of women who develop PID.
Wow. A quarter of them.
And it gets worse. If an egg is fertilized but gets trapped by that scar tissue before it can reach the uterus, it implants right there in the tube.
And that results in an ectopic pregnancy.
Exactly. Women with a prior history of PID are 6 to 10 times more likely to develop an ectopic pregnancy.
And that is a massive surgical emergency.
It's a leading cause of maternal morbidity and mortality globally.
This moves the conversation from a minor, easily curable infection to a life-threatening event that permanently alters a person's future.
Yeah, absolutely.
But the tragedy doesn't stop with the mother. If we look at maternal-child transmission or perinatal transmission, the numbers are absolutely devastating.
This is perhaps one of the most heartbreaking aspects of global public health, specifically regarding maternal syphilis.
What does the data show there?
When epidemiologists looked at the data globally, they calculated that in a single year, 1.36 million pregnant women had active syphilis infections capable of transmitting the bacteria.
That's Treponema pallidum, right?
Yes, Treponema pallidum, transmitting it directly to their unborn children.
Treponema pallidum is a spirochete. It physically corkscrews its way through tissue. What does that do to a developing fetus?
It aggressively crosses the placental barrier and infects the fetus systemically. And the outcomes are catastrophic.
Just catastrophic.
Untreated maternal syphilis results in hundreds of thousands of adverse outcomes annually. We are talking about massive rates of stillbirths, neonatal death within the first weeks of life, severe prematurity, and congenital infection in live-born infants.
And what does congenital syphilis look like in a surviving infant?
It can cause severe bone deformities, blindness, and profound neurological damage.
And what makes this an absolute tragedy, what makes it almost unbearable to read about in the text, is that syphilis is entirely preventable and curable with penicillin.
Yes, a single dose of benzathine penicillin in early pregnancy.
A cheap, widely available, out-of-patent antibiotic could prevent over 500,000 adverse pregnancy outcomes a year. It's a colossal failure of the system to screen and treat the asymptomatic root network.
It is a systemic failure, and if we zoom out and connect this to the bigger picture of viral STIs, we see another delayed systemic impact on orthogenesis.
The biological link to cancer.
Right. We know certain viral STIs have a direct mechanism connecting them to malignancies decades later.
HPV and cervical cancer being the primary example. I think a lot of people know there is a link, but for the medical students listening, how does a virus actually cause cancer?
It's a fascinating and insidious process. When an oncogenic strain of HPV, primarily types 16 and 18, which are responsible for about 70% of all cervical cancers worldwide, infects the cervical tissue, it doesn't always kill the host cell.
Okay, what does it do instead?
Instead, the viral DNA integrates itself directly into the host cell's DNA. And it starts producing viral proteins, specifically E6 and E7, that actively switch off the cell's tumor suppressor genes.
So it's basically cutting the brakes on cell division.
Exactly. Without those brakes, it causes the cells to divide uncontrollably, leading to slow, abnormal cellular changes called dysplasia.
And if that's not caught,
If the immune system doesn't clear the virus, That dysplasia can progress into invasive cancer over the course of 10, 20, or 30 years.
This requires serious long-term systems thinking from public health officials. You are fighting a war today for casualties that won't show up until 2050,
It dictates the absolute necessity of secondary prevention.
meaning screening.
Right, you need long-term structural screening programs like pap smears or direct visual inspection to catch those dysplastic cellular changes early and physically remove them before they become invasive.
And primary prevention too, right?
Yes, more recently it dictates primary prevention through HPV vaccines. The epidemiological models show that comprehensive vaccination campaigns are incredibly cost-effective.
They prevent the exposure entirely.
Exactly. And they are capable of profoundly reducing the future global cancer burden. We also see this oncogenic link with hepatitis B and C, by the way.
Right, causing chronic liver inflammation.
Yes, which eventually leads to hepatocellular carcinoma, accounting for hundreds of thousands of deaths annually.
There's another biological mechanism in the data that is absolutely fascinating and, frankly, terrifying. Epidemiological synergy.
Ah, yes.
This is the concept of how STIs act as biological amplifiers for HIV. When I first read about this, it was a massive aha moment for me.
It's a crucial concept.
I had always assumed that if someone had multiple STIs, it was just a statistical coincidence based on behavioral risk. You know, you take risks, you catch multiple bugs. But there is an actual physical mechanism at play here.
The synergy between STIs and HIV is a textbook example of how pathogens can inadvertently collaborate to co-opt the host's biology.
How does that work?
It happens in two primary physical ways. First, consider STIs that cause genital ulcers, like syphilis, chancroid, or HSV-2.
They are physically destroying the mucosal barriers. They're creating a literal open wound in the body's armor.
They do. The ulcer is a direct portal into the bloodstream and the lymphatic system.
It's like leaving the gates of a fortress wide open during a siege. If I have an ulcer from HSV-2, I'm essentially rolling out the red carpet for HIV to enter my system.
That's a great visual.
The virus doesn't have to work to get past the mucosal defenses. The door's already broken down.
The physical breach is a major factor, but the second mechanism is even more insidious, and it involves non-ulcerative STIs that cause inflammation, like gonorrhea or chlamydia.
Okay, so these don't cause open wounds.
Right. Even without an open wound, the bacterial infection triggers a massive immune response. The body sounds the alarm and sends an army of white blood cells straight to the site of the infection in the genital tract to fight the bacteria.
Right, and the specific white blood cells it sends are macrophages and CD4 plus T cells.
Yeah. Exactly.
But wait, CD4 plus T cells are the exact target cells that HIV infects.
That is the evolutionary cruelty of it. The bacterial STI summons the very cells HIV needs to replicate, dragging them right to the front lines of exposure.
That is staggering.
The body is essentially delivering the exact fuel HIV needs to start a systemic fire. It provides the virus with an overwhelming abundance of targets at the exact anatomical site where exposure is happening.
The body's own defense mechanism against chlamydia becomes the very thing that guarantees an HIV infection takes hold.
And it works in reverse as well.
What do you mean?
If a person is already living with HIV and they contract an active bacterial STI, the resulting genital inflammation drastically increases their localized viral load.
Oh, wow.
They shed far more HIV virus in their secretions, making them exponentially more likely to transmit HIV to someone else. It is a deadly, synergistic loop.
Okay, so we have mapped the catastrophic outcomes. We're looking at a landscape of permanent infertility, 500,000 neonatal deaths, slow-moving cancers, and the biological amplification of the HIV epidemic.
It's a grim picture.
If you are a public health official looking at this, the question is, how do we engineer a response? We can't just throw antibiotics at random people.
Yeah.
We have to turn chaotic human behavior and complex pathogen biology into a mathematical framework.
To do that, epidemiologists rely on the transmission dynamics model. This was famously formalized by researchers May and Anderson back in 1987.
Right.
It revolves around a single central concept, the basic reproductive rate of an infection, denoted as R0.
Right, R0. We heard this term a lot during the COVID-19 pandemic, but let's really break down the formula for you listening. The equation is R0 equals beta times C times D.
Yes, R0 equals VecBD.
What does this actually mean in a practical sense?
R naught represents the average number of new infections generated by each infected person in a completely susceptible population.
So it's a tipping point.
It is the mathematical tipping point of an epidemic. If R naught is greater than 1, every infected person is passing it to more than one other person, and the epidemic grows exponentially.
And if it's less than 1?
If R naught is less than 1, the pathogen isn't replacing itself fast enough, the epidemic shrinks, and it eventually dies out. The beauty of the formula is that it isolates the 3 distinct levers we can pull to force R naught below 1.
Okay, I want to try and define the variables. You tell me if I'm thinking about this correctly.
Go for it.
Let's start with beta. I would imagine beta is the biological efficiency of the bug. It is the probability of transmission per sexual act.
Mm-hmm.
How likely is the pathogen to actually jump from an infected person to a susceptible person during a single encounter?
You've got it. And beta is influenced by both the pathogen and the host. For example, HIV actually has a relatively low beta per single sexual act compared to something like gonorrhea, which is highly infectious.
Oh, really?
Yeah. But beta can be altered. If a person has an active genital ulcer, as we discussed, their beta for acquiring HIV skyrockets.
Okay, moving to the next variable, little c. This has to be the behavioral aspect. The average number of new sexual partnerships formed over a given period of time.
Correct. It is a measure of the velocity of partner change within a specific network.
And finally, big D. This is the duration of infectiousness. How long is the infected person walking around capable of transmitting the pathogen to others?
That is the final piece of the puzzle. Now, the genius of this framework is that it categorizes our entire medical arsenal. Every single public health intervention we have ever devised targets one of these 3 specific variables.
Here's where it gets really interesting. Let's look at big D duration. If I'm a public health official, how do I attack D?
Targeting D is the traditional historical backbone of STI control. If a person is going to be infectious for 6 months if left alone, our goal is to find them at week 2.
Cut the timeline down.
Exactly. We use active screening programs to find them quickly, treat them with antibiotics, and cure them. We just drastically reduced their D variable from 6 months to 2 weeks.
And what about partner notification?
Partner notification programs do the exact same thing. By tracking down the infected contacts and treating them before they even develop symptoms, we cut their duration of infectiousness to almost 0.
What about beta transmission efficiency? How do we alter the biology of the jump?
Interventions targeting beta aim to make the sexual act itself less physically risky. The most obvious example is the condom, which provides a physical barrier, dropping beta significantly.
Right. Condoms are classic beta reduction.
But it also includes male circumcision, which alters the genital anatomy by removing mucosal tissue rich in HIV target cells, thereby reducing acquisition risk.
That makes sense based on the cellular biology we talked about.
And today, it heavily features pre-exposure prophylaxis, or PCAR-P, where high-risk individuals take antiviral medications daily.
So the virus gets in, but it can't set up shop.
Exactly. The virus might enter the body, but the medication prevents it from establishing an infection. Pre-AP is a massive strike against the beta variable.
And finally, little c, the number of partnerships. I have to imagine this is the most difficult lever to pull.
It is notoriously difficult because it involves deeply ingrained human behavior, complex social dynamics, and personal autonomy.
You can't just mandate human behavior.
No. Interventions here include behavioral counseling aimed at reducing the overall number of concurrent sexual partners or promoting mutual monogamy.
What about abstinence programs?
Historically, there have been massive investments in abstinence-only programs, but the epidemiological data consistently shows they have very limited effectiveness in sustainably lowering C at a population level.
So if I'm picturing this equation,
Yeah.
D is basically how long the fire burns. Beta is how dry the wood is, determining how easily a spark catches. And little c is how close the trees are together in the forest.
I love that analogy.
Thanks. If we can't easily change human nature to stop the trees from being close together, if we can't easily reduce C at a population scale, we must invest heavily in putting the fire out faster by reducing D, and we have to soak the wood to make it fireproof by reducing beta.
The forest fire analogy is brilliant because it captures the dynamic nature of an epidemic, and it leads directly into another crucial mathematical concept regarding the trees in your analogy: sexual networks and core groups.
A topology of the forest.
Right. People are not just random dots bouncing around a map like gas molecules in a jar. They are nodes in a highly structured topological network.
The actual physical structure of the network matters just as much as individual behavior.
Yeah.
If you think about airline flight maps, A delayed flight at a tiny regional airport in Montana doesn't affect the national grid,
Right.
but a blizzard at a major hub like O'Hare or Atlanta cascades across the entire system.
The hub and spoke model applies perfectly to epidemiology. The data defines core groups as subpopulations with high rates of new partner change.
Their little c is very high.
Their individual C variable is so exceptionally high that they maintain an R naught greater than 1 purely within their own subgroup.
Wow.
Because of their central location within the broader sexual network, they act as the hubs. They are the engines driving the epidemic.
So from a mathematical perspective, public health doesn't necessarily need to blanket the entire population with intense, expensive interventions.
The math tells us that blanket strategies are highly inefficient. Targeted interventions focused specifically on those core groups are mathematically far more powerful.
Who typically makes up these core groups?
They often include sex workers, highly mobile populations like truck drivers or minors, or individuals presenting with repeat STIs. If you can lower the prevalence within a core group hub, you disrupt the engine.
And the whole system calms down.
Yes. The R naught for the entire broader network drops even if the behavior of the general population doesn't change at all.
Okay, understanding the math and the network topology is incredibly satisfying when we were looking at a textbook model. But the math exists in a vacuum.
Very true.
What happens when a real complex human being actually walks into a real underfunded clinic? We have to look at the friction of reality.
This is where public health moves from theoretical mathematics to the gritty reality of healthcare delivery. We use a conceptual framework called the Pettit-Franson model to understand this friction.
The Pettit-Franson model.
Yes, it functions as a pipeline, a visual representation of the steps a person must take to actually get cured. But it is a very, very leaky pipeline.
Let's bring this to life. Let's trace a hypothetical person, we'll call her Sarah, through this pipeline in a resource-limited setting.
Okay. Imagine a community where 1,000 women have an active chlamydia infection. Sarah is one of them. The very first leak in the pipeline is the biological reality we discussed earlier: symptoms.
Right, most STIs are asymptomatic.
So immediately, 700 of those women feel fine and stay home. The pipeline shrinks dramatically right there.
So we're down to 300.
Sarah happens to be one of the 300 who actually develops symptoms.
But having a symptom doesn't guarantee a cure.
Not at all. Sarah feels unwell, but she might be paralyzed by the profound social stigma of being seen at an STI clinic. Or perhaps she doesn't have the health literacy to recognize the symptom as an STI.
So she just waits to see if it goes away.
Exactly. She doesn't seek care. That is another massive leap.
And if she does decide to seek care?
Let's say she does, but the formal clinic is a 3-hour bus ride away, and she can't afford the ticket or the time off work. So she goes to an informal pharmacy in her village instead. Another leak.
The friction just keeps compounding.
It does. Let's say Sarah makes it to a formal health unit. She sees a clinician. The clinician might misdiagnose her or prescribe an antibiotic that the local bacteria are already resistant to.
Leak.
Let's say she gets the right drugs. She takes them for 2 days, feels better, and stops taking them to save the rest of the pills for later, never actually clearing the infection.
Another leak.
And the final, most frustrating leak of all.
Partner treatment.
Yes. Even if Sarah navigates that entire pipeline, she seeks care, gets the right diagnosis, takes the full course of pills, and is completely cured, if her partner is never treated, she will simply be reinfected the very next time they are intimate.
So she's right back where she started.
The Pettit-Franson model demonstrates that when you account for all of this real-world friction, the proportion of total infected people in a community who actually achieve a permanent cure is vanishingly small.
That leaky pipeline highlights exactly why we have to differentiate between screening and case management. If we rely on case management, we're just waiting at the end of a broken pipe for the few drops that make it through.
You've nailed it. Case management is fundamentally passive. It only deals with the symptomatic patients who actively seek help, the Sarahs who fight through the friction.
And screening.
Screening, on the other hand, is active. It proactively hunts for the asymptomatic, subterranean cases in high-risk populations.
What's a good example of that?
Routine annual chlamydia screening for young women is a prime example. You test them when they come in for a completely unrelated visit, like a birth control refill. It bypasses the first few leaks in the pipeline entirely.
But when a patient does show up at a clinic with symptoms, the provider has to make a choice about how to treat them right then and there.
Yes, clinical decision-making.
The data outlines two fundamentally different approaches: etiological versus syndromic management. I know etiological management is what most people in high-income countries expect when they go to a doctor.
Yes. Etiological management is pathogen-specific. The provider takes a swab or a urine sample, sends it to a laboratory, and uses a sophisticated diagnostic test.
Like a NAT test.
Exactly, a nucleic acid amplification test, or NAT, which searches for the specific genetic material of the bug to identify the exact pathogen causing the problem.
So it's highly accurate. The doctor knows exactly what enemy they're fighting.
It is the absolute gold standard of care. But consider what it requires. Massive, sustained infrastructure.
Oh, right.
You need expensive, calibrated equipment. You need highly trained technicians. You need climate-controlled labs with reliable electricity.
Which a lot of places simply do not have.
And crucially, you need time. The patient has to leave the clinic and come back 3 days later for the results.
And in the context of the Piet-Franson pipeline, asking a marginalized patient in a low-resource setting to spend money on a second bus ticket to come back for test results guarantees you will lose them.
Exactly. The patient never returns and the infection goes untreated, which is why the World Health Organization pioneered a totally different approach back in the 1970s and 90s, syndromic management.
How does syndromic management bypass the lab?
It was designed specifically for low-resource settings without laboratory capacity. Instead of diagnosing the specific biological bug, the provider diagnoses the clinical syndrome, a constellation of easily recognizable clinical signs.
Like what?
Like abnormal vaginal discharge or a genital ulcer. The provider is given a standardized, simple flowchart.
So if a patient presents with a genital ulcer, the flowchart doesn't ask the clinician to figure out if it's syphilis, chancroid, or herpes.
No, not at all.
It just says, patient has an ulcer, give them an injection of penicillin to cover syphilis and an oral antibiotic to cover chancroid right now before they leave the room.
That is the exact protocol. It is an algorithm of empirical, on-the-spot treatment. It is immediate, it is cheap, it doesn't require a microscope, and it completely eliminates the risk of the patient being lost to follow up because they receive the drugs directly in their hand.
But when you look at the epidemiological outcomes over the decades, there is a lot of critical analysis regarding the massive flaws of the syndromic approach.
It has severe systemic limitations. First and foremost, as we keep hammering home today, it only treats symptoms. Therefore, it completely misses the vast subterranean network of asymptomatic infections.
Because they never enter the flowchart.
Right. Second, many syndromes are not highly specific. Vaginal discharge, for example, is frequently caused by non-STI factors like bacterial vaginosis or yeast infections.
Oh, so they get treated for an STI they don't have.
If you use the syndromic flowchart, you end up giving powerful antibiotics to millions of women who don't actually have an STI, driving massive overprescription and resistance.
And third, it makes partner notification incredibly confusing.
Because you don't actually know what you are treating. How do you counsel a patient to go tell their partner they have a highly infectious disease when you, the doctor, can't even tell them which disease they have?
It sounds like syndromic management is like using a shotgun because you can't afford a sniper rifle. It might hit the target, but there is a tremendous amount of collateral damage, and you completely miss all the enemies hiding silently in the bushes.
That is a grim but remarkably accurate way to look at the reality of global health logistics, which brings us to a larger, almost philosophical point.
What's that?
If we have the sniper rifles, if we have the NAT tests, the powerful antibiotics, the HPV vaccines, and the brilliant mathematical models, why do STIs still thrive globally? Why haven't we eliminated them?
Because, as the epidemiological data explicitly notes, biology and social context are inseparable.
They are intertwined.
A clinical intervention, no matter how scientifically advanced, is absolutely useless without what public health experts call an enabling environment.
Structural determinants dictate the ultimate success or failure of public health. An enabling environment requires political will, consistent funding, and a supportive legal milieu.
It's beyond just medicine.
You can have shipping containers full of the best antibiotics in the world, but if the legal framework of a country drives your core groups underground, your R0 will never drop below 1.
Let's look at some historical case studies in governance that illustrate this purely from an epidemiological perspective.
Yeah.
Let's look at the math of policy. Thailand in the 1990s is a classic example cited in the text.
Thailand faced a massive, exploding HIV and STI epidemic driven largely through commercial sex networks.
What did they do?
Rather than driving the core group into hiding through punitive measures, the government threw massive political support behind a 100% condom use program specifically designed for sex workers and entertainment establishments.
And we are impartially reporting this as a public health strategy.
Yes. They provided the resources, the education, and the structural support to enforce it across the board.
They soaked the wood to reduce the beta variable and the epidemiological result.
A staggering 95% reduction in curable STIs nationwide. By acknowledging the core group and providing an enabling environment, they disrupted the mathematical engine of the epidemic.
And then there's the historical case of Senegal.
Senegal took a unique approach by implementing the decriminalization of sex work. If we look at this purely through the lens of data and access to care, the impact was profound.
Because the legal threat was gone.
Because the legal threat of arrest was removed, public health workers didn't have to hunt for patients in the shadows. They could safely conduct outreach, provide accessible screening, and distribute targeted treatments to sex workers in the open.
It removed the friction for the Piet Franzen pipeline.
Exactly. The women weren't afraid to go to the clinic. The epidemiological result was that STI and HIV prevalence in Senegal remained moderately low and remarkably stable, standing in stark contrast to neighboring countries that lacked those protective legal frameworks and saw their epidemics explode.
The legal environment also heavily impacts how we handle the D variable, the duration of infectiousness, specifically regarding partner notification.
Yes, partner management is deeply affected by policy.
We established earlier that treating the partner is the only way to stop the ping-pong effect of reinfection. But the logistics of getting a partner into a clinic are notoriously terrible.
The logistics are incredibly complex. Traditionally, we rely on patient referral, asking the patient to go home and tell their partner to come to the clinic.
Which doesn't always go well.
No, because relationships are fraught with power dynamics, fear, and potential violence. Or we rely on provider referral, where a health worker confidentially contacts the partner. But health departments are universally understaffed.
Right.
However, there is a highly effective alternative public health tool called expedited partner therapy, or EPT.
EPT is fascinating. How does it physically work?
With EPT, the clinician diagnoses the index patient with something like chlamydia. Instead of asking the partner to come in, the clinician hands the patient a second prescription, or even the actual physical medication in a little packet to take home and give directly to their partner.
Oh, wow.
The partner takes the pills without ever having to set foot in a clinic, register their name, or be examined by a doctor.
It brilliantly bypasses the entire leaky pipeline for the partner. But I imagine that runs into massive legal and regulatory barriers.
Oh, absolutely.
A doctor is essentially prescribing medicine for a ghost, someone they've never met, examined, or taken an allergy history from.
The legal friction is immense. The laws regarding whether a nurse or even a doctor can legally prescribe drugs to an unseen patient or whether EPT is permissible at all vary wildly by country and even by state or province.
So it's not a universal tool yet.
Some jurisdictions embrace it as a vital public health tool. Others explicitly ban it as medical malpractice. This is a prime example of how the legal milieu acts as a structural determinant of health, directly impacting our ability to lower that D variable.
So if we look at everything we've discussed so far, public health officers have to be part doctor to understand the cellular biology, part mathematician to calculate the R-naught, and part politician to navigate the legal frameworks.
Let's look at how that actually plays out on the ground regarding stigma.
Okay.
Stigma is often talked about as just an emotion, someone feeling embarrassed or ashamed. But in the context of global health, stigma is not an emotion. It is a tangible structural barrier that physically blocks access to care.
Right. It stops the action.
It stops the teenager from buying condoms. It stops the sex worker from entering the clinic. It stops politicians from funding screening programs. Stigma directly, mathematically, raises the D's variable in our R-naught equation by keeping infectious people isolated from the cure.
We have mapped the current battlefield. We understand the math, the friction, and the policy. But pathogens are not static entities. They are living, evolving organisms.
They certainly are.
What are the emerging threats, and what new weapons were we developing as we look to the future?
The most sobering analysis we face today concerns the superbug threat. Specifically, the terrifying rise of antimicrobial resistance, or AMR, in Neisseria gonorrhea.
Gonorrhea, a bacteria we've supposedly been able to cure for almost a century.
Neisseria gonorrhea is a highly active, highly adaptable organism. It is a master of genetic mutation and acquiring resistance genes from other bacteria.
It's a survivor.
If you trace the historical arms race, it is a story of continuous bacterial victory. We threw sulfonylamides at it in the 1940s. It developed resistance. We switched to penicillins. It beat them in the 1970s.
Wow.
We moved to tetracyclines in the 80s and fluoroquinolones like ciprofloxacin in the 90s and 2000s. The bacteria systematically defeated every single class of drug we deployed.
So what is left in the arsenal?
We are now down to our very last line of defense, the third-generation cephalosporins, specifically an injectable antibiotic called ceftriaxone.
And is that holding?
Barely. The global surveillance networks are sounding the alarm. The minimum inhibitory concentrations, the amount of drug required to kill the bug are rising steadily around the world. Highly resistant strains, often called supergonorrhea, are already emerging and spreading internationally.
Meaning we are staring down the barrel of untreatable gonorrhea, an era where an incredibly common, fertility-destroying infection simply cannot be stopped by modern medicine.
The threat is severe enough that the WHO launched JSP, the gonococcal antimicrobial surveillance program, to try and monitor this resistance globally.
How is that going?
It is incredibly difficult. Bacteria is fastidious, meaning it dies easily in transport. And ironically, as high-income countries have switched to the highly accurate NAT tests, the sniper rifles we talked about, our global culture capacity has declined.
Oh, because the NAT test just looks for DNA.
Exactly. NATs detect the DNA, but they don't give you a living bacterial sample that you can test against different drugs to monitor for resistance. We are losing our early warning radar.
So with gonorrhea, we are basically in a slow-motion evolutionary arms race, and right now, the bacteria is winning.
Let's try to pivot to some technological optimism.
We definitely need some optimism.
How is modern technology changing the landscape in our favor?
There is a massive source of optimism in the realm of mHealth, or mobile health. Mobile phones have achieved incredible global penetration, reaching deeply into low-income and rural settings where physical clinics are scarce.
How does that help with STIs?
This technology allows us to bypass geographical barriers, and crucially, it bypasses stigma.
How does a phone bypass stigma? Are we talking about using SMS text messages for confidential partner notification?
That is a primary application, yes.
Yeah.
An automated anonymous text message informing someone they have been exposed and providing a link to the nearest clinic is far less daunting than a face-to-face confrontation.
That makes a lot of sense. Health is also used for appointment reminders, ensuring patients finish their antibiotic courses, and delivering targeted private sexual health education directly to marginalized youth. It is about just-in-time interventions.
What about diagnostics?
The most significant technological leap we are seeing is in the realm of diagnostics.
This goes back to solving the fundamental flaw of syndromic management, right? Giving clinics in low-resource settings a sniper rifle instead of a shotgun.
Precisely the goal. We need to replace the flawed syndromic flowcharts with rapid point-of-care tests. Tests that give you a definitive biological answer while the patient is still sitting in the chair.
And what's the standard for that?
The gold standard for these tests in global health is defined by the assured criteria.
Let's break down that acronym because I think it perfectly illustrates the friction of global health delivery.
Assured is an acronym developed by the WHO. The test must be A, affordable by those at risk of infection,
Which is key.
it must be S-sensitive, meaning it avoids false negatives, and S-specific, meaning it avoids false positives.
Okay, that's ASS.
It must be user-friendly, requiring only a few simple steps with minimal training for the health worker. It must be R, rapid and robust.
What does robust mean in this context?
No, it needs to give results in minutes, not days. And it must survive transport in hot, humid climates without needing a cold chain or refrigeration.
Ah, right, the logistics.
It must be easy equipment free, meaning no complex centrifuges or microscopes required. And finally, it must be de-delivered to those who need it.
That is an incredibly tall order for a medical device. Have we actually achieved that for any major STIs?
We have, and it is revolutionizing care. The most prominent success story is the rapid treponema test for syphilis.
How does it work?
These little test strips have utterly transformed antenatal care. A pregnant woman in a remote rural clinic without electricity can be tested with a simple finger prick.
Wow, just a finger
The
prick.
health worker reads a colored line on the strip 20 minutes later, and if it is positive, the woman is treated with a curative injection of penicillin on the spot before she even walks out the door.
That single technological advance, a tiny piece of treated paper, can intercept the maternal-child transmission pipeline.
It's incredible.
It is a major factor in the global push to finally eliminate congenital syphilis. With rapid testing, we are finally moving the laboratory out of the high-income ivory tower and into the patient's living room, or at least into the rural primary care clinic.
It is the ultimate intervention against the D variable. It brings the diagnosis right to the point of contact, shrinks the leaky pipeline of the Piet-Frantzen model to zero, and stops the transmission before the patient ever leaves the room.
This has been an incredibly dense, fascinating journey through the subterranean root system of global health. We've covered the biology, the complex math of R0, the friction of human behavior, and the evolutionary arms race.
We've covered a lot of ground today.
But before we wrap up, I want to leave you, the listener, with a provocative final thought. A systemic collision we all need to prepare for.
Think about the future.
Think about the intersection of climate change and mass human migration in the coming decades. If stable populations with established health systems and steady sexual networks are disrupted by extreme weather or conflict, people will move.
They will be forced to move.
They will be forced into refugee camps, transitional housing, and entirely new geographic regions. When those highly structured sexual networks are shattered and reformed, and when those migrating populations lose all access to routine screening and antibiotics, how will that alter the R0 of these ancient pathogens globally?
The math is going to change dramatically.
The math is going to change, and public health must be ready to adapt.
That is a critical systems-level question that the next generation of public health leaders will have to solve. And to ensure the core conceptual frameworks from today's deep dive are firmly anchored in your memory, we are going to run through 6 rapid single best answer prompts.
Get ready to test your knowledge.
I will read the question, take 3 seconds, 1, 2, 3, so you can lock in your answer, and then provide the correct response in the conceptual area for review.
Take it away.
Question 1. In the R0 equation for STI transmission dynamics, which specific variable do syndromic case management and partner notification primarily aim to reduce? 1, 2, 3. The answer is, they aim to reduce D, the duration of infectiousness. Revisit the transmission dynamics section of the chapter for consolidation. Question 2. Which STI is a bacterial infection that has systematically developed antimicrobial resistance to nearly all classes of antibiotics, leaving third-generation cephalosporins as the last line of defense? 1, 2, 3. The answer is Neisseria gonorrhea. Revisit the antimicrobial resistance section. Question 3. What is the fundamental limitation of syndromic case management when applied at a population level? 1, 2, 3. The answer is it almost entirely misses asymptomatic infections, which represent the vast majority of curable STIs. Revisit STI case management. Question 4. By what biological mechanism do non-ulcerative STIs, like chlamydia and gonorrhea, enhance the acquisition of HIV? 1, 2, 3. The answer is by causing intense mucosal inflammation, which actively summons and increases the concentration of HIV target cells, like CD4 plus T cells, right at the site of infection. Revisit the STI-associated morbidity section. Question 5. In the context of global health point-of-care diagnostics, what does the E in the assured criteria stand for? 1, 2, 3. The answer is equipment-free, meaning it does not require complex laboratory infrastructure or electricity. Revisit the new STI diagnostic section. Question 6. Which viral STI is responsible for approximately 521,000 adverse pregnancy outcomes globally, including stillbirths and neonatal deaths, despite the existence of a cheap curative antibiotic? 1, 2, 3. The answer is trick question. Syphilis is the correct answer regarding the mortality statistics, but it is a bacterial STI, not a viral one. Always read the pathogen type carefully. Revisit STI-associated morbidity.
And that brings us full circle. Remember, the true ecosystem of transmission is underground. You can't just treat the visible weeds. You have to eliminate and dismantle the roots. Here are the details of this episode.
Sexually transmitted infections, byline, epidemiology, prevention strategies, and the intersection of behavior, stigma, and structural determinants. Full obit episode description. Sexually transmitted infections, STIs, remain a significant global public health challenge, with millions of new infections occurring each year. While many STIs are preventable and treatable, persistent stigma, inequitable access to services, and social determinants continue to drive transmission. This episode explores Global epidemiology of major STIs, chlamydia, gonorrhea, syphilis, HPV, and others. This episode explores transmission dynamics and behavioral risk factors. This episode explores screening strategies and asymptomatic infection. This episode explores antimicrobial resistance in gonorrhea. This episode explores HPV vaccination and cancer prevention. This episode explores maternal-child transmission. This episode explores sexual health education and harm reduction. This episode explores stigma, discrimination, and access barriers. This episode explores integration of STI services within primary care. This episode explores STIs demonstrate how biology and social context are inseparable. Patterns of transmission reflect sexual networks, healthcare accessibility, education systems, and broader social norms. Public health responses must balance individual confidentiality with population-level surveillance. This episode explores. The episode emphasizes prevention through vaccination, screening, partner notification, and comprehensive sexual health education, while recognizing that stigma undermines engagement and trust. This episode explores. Sexual health is fundamental to overall health, autonomy, and equity. This episode explores. This episode explores key takeaways. This episode explores STIs remain highly prevalent globally. This episode explores many infections are asymptomatic but transmissible. This episode explores screening and early treatment reduce complications. This episode explores antimicrobial resistance threatens effective treatment options. This episode explores HPV vaccination significantly reduces cancer risk. This episode explores a stigma is a major barrier to prevention and care. This episode explores integrated confidential services improve outcomes.